Good afternoon. My name is Dr. Colt, and I am a Texas licensed physician and a Texas licensed psychologist, the only person in our state to hold both distinctions. I was born and raised in Texas. I went to Catholic schools in Beaumont, Texas. I went to Rice University and U of H in Houston. I completed my MD at UTMB in Galveston. So I am your Texan. I'm currently in my final days of my family medicine residency at the Mayo Clinic up in Minnesota, but this is so important to me that I came here. I've been conducting research in the area of transgender health and providing health care to this population since my early days in training in 2009. My dissertation is the first study in Texas to demonstrate the positive mental health benefits of hormone therapy using a longitudinal and controlled design. I am representing myself in my strong opposition to this bill. In fact, it's because of bills like these that I made the decision not to return home to Texas to practice. A theme that keeps coming up in our legislature bills that is to restrict and to deny rights to my people, from bathrooms to sports and now healthcare. I'm here because of the harms this bill has already caused and will cause in the future, should it pass. As part of my testimony, I have 18 empirical peer-reviewed research studies that demonstrate positive health effects in healthcare in this population. Time and time again, you'll review the findings of improved quality of life, body image, depressive and anxiety symptoms, and decreases in suicidality. As the committee is well aware, this community is at high risk for suicide. So why would you want to ban life-saving treatments in my community? Because that's what the bill clearly communicates. What do you want me to tell my patients when they ask me why you don't want them to have health care?
Bruh.
I feel very confident in the treatment guidelines and the standard of medical care that exists to guide our intentional and careful assessment and treatment of transgender adolescents and adults. We've had guidelines since the late 1970s, which continue to be updated based on the most recent research, as with all medical care. These guidelines exist to make sure that youth and families are protected. The standard of care for adolescent healthcare is interdisciplinary in its nature. There are multiple team members that work with each family to determine the best treatment recommendations based on each individual case. And as with all medical treatments, risk and benefits are clearly communicated and reviewed with parents and youth to make informed decisions.
Risk and benefits are clearly communicated and reviewed with parents and youth to make informed decisions.
Physicians should know that low-quality evidence is not the colloquial low-quality term. There's an actual standard that is set, and if it's an observational study, it won't get any higher than low-quality evidence because of the nature of the design of the study. Doesn't mean it's a poor study, doesn't mean it's a bad study. Things that we do routinely in medical care, like Tamiflu, vitamin D, Aricept for dementia, and statins are all based on low quality evidence, but they are the standard of care, and you're not trying to ban those.
To speak on another witness that I'm sorry I didn't catch the name, but they're from the Mayo Clinic, made the statement about how, well, there are other interventions that we do, such as Tamiflu or vitamin D, that have poor quality evidence, but yet we still allow them to be administered in the medical community. The difference is that there's no measurable harm with those interventions, but there is measurable harm with gender-affirming care.
I understand and I share the common concern that we need to protect young people from receiving treatments that they do not need, that are not medically necessary. However, a complete and total ban on care that some Texas adolescents actually do need is not only unethical, but unconscionable. My question for y'all is, how do we work together to protect the adolescents who really do need this treatment, as well as those who do not? Thank you.
Johnson, thank you so much. You mentioned that you want to be part of this dialogue, that we should not have kids getting treatment that they don't need, but that this ban would go the opposite other way. What would you describe as that middle ground in our creating state policy?
I think it should be very clear that the professionals who provide this care should be required to have training and continuing education in this area. There are plenty of people that put up their shingles and say they work with transgender patients that I've never seen at professional conferences. I have no idea who they are, where they came from, and are giving parents information that I'm not sure where they got that information from. So I would be a big fan of making sure that we hold all professionals to the standard that they're supposed to have of practicing within their scope of practice, and making sure that they are educated on the care that they're providing, and that they're not just done once they've gone to one conference, that they participate in continuing education in this area. They also, if we're working on with adolescents, which is what we're talking about here, we need to have folks who work in multidisciplinary teams. Now, they can be spread out. So a therapist can be in San Antonio and somebody else can be in Austin, and the family can, work with two different cities. That's fine. They don't have to be in a clinic altogether, because that's not really feasible and will reduce access to resources. But we need to make sure that we support these interdisciplinary teams who are trying their best to provide really good care to these families. Those would be two of my suggestions.
We heard earlier some of the testimony and somebody with regard to research and all of these differing studies. Would it be fair to say, two questions here?
Sure.
One, that hormone therapies and hormone treatments are long held and have a reliable practice. Yet where we are now with gender dysphoria, we again may be in the beginning of a stage of medical practice where we may continue to see evolution, and we should be part of a science-based study in that area.
I definitely think we should continue the research. It's been done since the 1990s, so it's not brand new compared to a lot of medical treatments that we have these days. It's actually quite old, even with transgender patients. And so we do have over 30 years of documented research. So sometimes people say, oh, this is brand new. And I would say that's not consistent with my understanding and expertise in this area. So I do think we definitely need to continue studying. The challenge is, where's the funding going to come from? I've had to piece together all sorts of different funding because nobody really wanted to support this research. And I'm not sure I can count on my state to give me funding for it. That, you know what I mean? So if we're really invested, if we really want to do the study, then we need to front the funds in order to support this as well, if we're really that concerned.
And what about the issue of puberty blockers or hormone treatment? What would you say to that?
What's the specific question, Representative?
So is the practice of puberty blockers or hormone treatment, we've heard about things like precocious puberty. Does the medical profession apply? And even in this bill, we know that those treatments will be available to some, but not to those that identify as transgender. What's your take on that?
It's clearly discrimination. We're treating one group with the same medications that we're not treating the other group with. And again, we have research since the 1990s on pubertal suppression. We're having more and more data come out. So over 10 studies in the last 3 years to support the practice of pubertal suppression. So the idea that only some people should be able to have access to treatments, but not the transgender people, for me is clearly discrimination. And if you're saying, oh, I'm going to argue, no, it's not, well, I'll tell you, it sure feels that way.
Okay, so I think in here I was reading, what percentage of it? 85% of children grow out of gender dysphoria by adulthood. So I have to ask this question that I think you'll have the answer to. Is it true that once a child is on Lupron, which is a puberty blocker, and then testosterone for a period of a few months or more, are they irreversibly sterile, or can they be?
It is my understanding that yet once they are on cross-sex hormones, that and I don't know the magic amount of time frame. I don't know that anybody actually knows that, but yes, they are irreversibly sterile with the cross-sex hormones. If I could just say one thing that about the 85% statistic, it's not contentious at all that the majority of children, minors, desist if we allow them to. And so the doc from Mayo Clinic made the statement, 18 months to 4 years, I believe, is the time when the brain develops gender identity. Well, even according to the DSM-5, which is the American Psychiatric Association, hardly a bastion of conservative medical thought, right? They even say in their own document, the majority of minors will desist. And so it wasn't 85%, but they're included in that, the vast majority desist.
Let me also ask, earlier we heard testimony from Libby's father. And Libby's father talked about Libby starting to get to a point of having trouble sleeping with fear that Libby's body was going to begin to change. And I've heard my colleagues say, why don't we just keep up mental health treatment until people get to 18? How do you correlate that with somebody like Libby, whose father genuinely let us know about the authenticity of the love for that child and the authenticity that that child has for who she is? How do you balance that concept of just give mental health treatment until 18 with somebody who is actively already identifying that puberty is not going to be okay for them?
Absolutely. Denying access to medically necessary care is not neutral and is harmful. And I'll ask one of my assistants to bring me my stack of research papers, because there's actually one that uses a control from the Netherlands that looks at youth who just have psychological counseling and then compares them to youth with psychological counseling and pubertal suppression. And guess which group does better in terms of mental health? Those who have access to both counseling and pubertal suppression, but we just give pubertal suppression to anybody after the appropriate assessment and diagnostic workup.
And what would your fear be if Texas passed this bill that says all of a sudden, no more care? What would we do about those population of children who are already receiving care here in Texas?
Yes, we'll continue to see the development of many folks' mental health, and so the deterioration. So I've already seen this, and I'm openly transgender myself, and I have access to community, and so I see as both a professional my own patients, and then as a member of my own community. So I have both insights, if you will, personal and professional expertise. And what I see is folks have been so scared already, just that we're debating if they could even access care in their home. And so I know many families who have already moved out of state preemptively. And y'all know moving out of state is not an easy task. And also these are families who have means. So we are going to disproportionately impact folks who don't have money to just leave the state. And that's going to impact Black and brown folks more, disabled folks more, folks who can't just get up and move. And so we're going to be harming already vulnerable populations, but even more folks with several disparities already. And I think the challenge is, and I know we want to be very sensitive to the suicide conversation because that is a real conversation. And I think there's been a lot of all over the place with that. But I do know that for some folks, treatment is a life or death issue. And I can say that with certainty. I've had, let me give you an example of, I'll de-identify so you don't.
Thank you, Doctor, for being here. Appreciate you taking the time. I'll tell you what I said to the last witness that I questioned is thank you for trying to make Texas a better place, and whatever side of the issue we fall on, taking part in this process does that. So where are you licensed to practice?
Medicine or psychology or both?
Well, both, actually. Yeah, thank you.
Sure. Psychology in Texas, and I have the SciPact certification, so 27 different states as well. And then medicine, Minnesota and Texas.
Minnesota, okay. And do you have like one office in a particular place, or do you have an office in both Minnesota and Texas, or?
Great question. So I'm in residency, and so I'm pretty much only doing residency. However, because of the extra special expertise I have in this area, there are folks who still want to see me outside of my residency, so in my psychology career. And so I do have an office down here, and whenever I'm visiting down in Texas that I can use, and also virtual support services down here in Texas.
So when were you licensed to be a psychologist?
I believe it was 2014 was when I was licensed to be a psychologist.
Okay.
And I've kept that license.
When did you receive it? So you have an MD degree?
I have an MD and a PhD.
When did you get your MD?
2020.
Oh, okay.
I've been going to school forever. But this is worth it, if that makes sense.
I understand. A moment ago, you said what we need is the appropriate assessment and workup. Yeah, I'll get you something to drink there.
We're good.
I think I need.
Glad to be here.
Yeah, absolutely. That made me start thinking about it. Can I have your water? Thank you very much. I just took water. Drink. Yeah, that's right. Sure. A moment ago, I thought I heard you say that the appropriate assessment and workup is necessary.
Absolutely.
Okay. In your experience as a psychologist in Texas, do you believe that the appropriate assessment and workup is being accomplished in Texas currently?
If families go to providers who know what they're doing, if folks are practicing in their scope of practice, absolutely.
And do you have an understanding do you have any idea as to what percentage of providers are doing that?
The ones in my network all are. But I've had a few patients come to me and tell me about people who have told them these other things. And then I get that corrected and I report those folks to their boards. Okay.
If you don't mind me asking, I think a moment ago you volunteered that you transitioned yourself.
Yes, sir.
How old were you when you began the process?
Sure. So informally, because I was born in 83 and then lived in Beaumont. And I wasn't bullied.
Did you ever go through a time where you went through, you had puberty blockers or some?
Oh, great question. In terms of my medical transition. Okay, so that was my beginning social transition. There wasn't pubertal suppression available. And in fact, the closest experts in care for transgender people were in Galveston, Texas. There wasn't anything in our medical center, our biggest area, our hugest area in the whole state. The medical center had nothing in Houston. And so I had to drive from Houston to Galveston, Texas for care and received hormone treatment there. And I, just so you know, I don't talk about my genitals in these public spaces, so I will not be answering questions about my genitals.
I won't be asking any about your genitals.
You'd be surprised. People do. And I just want to clearly communicate.
I will not do that to you.
I just want to clearly communicate.
So, no, thank you. So how old were you when that started?
Let's see. I was 23 when I learned what transgender was and was like, oh, got it. Because at first I was like 21, 22, and I was like, oh, I'm a lesbian because, I like women. But then I learned other lesbians didn't want to be men. I was like, oh, crud. I guess that's not it. And so then I met a transgender person and we call this phenomenon mirroring. I saw myself in someone in a way that I had never seen myself before.
Okay. Now, a moment ago, you were talking about, and I'm sorry for jumping around, but
It's getting late. You're all right. You've been doing your job.
that and cleanup. With regard to suicide,
Sure.
you talked about a real conversation.
I would love that.
What, I know we don't have all night here, but just tell me in summary, what do you mean by that? You're saying we have a real problem, we need to deal with it, need to have a real conversation, we need to have a real conversation about how we handle it, all of those things.
Absolutely.
Tell me what you mean.
Absolutely. We have clear data, multiple studies that show decrease in suicidal ideation with treatment. And I'm glad to bring all of those studies and put them right on your desk. And in my population, if I can get a decrease in people thinking about suicide, I don't care if it's my population or anybody else. I think that's good. I think that is good treatment. And I want to make sure that I have the ability to prescribe and have folks access that.
Do you have those with you?
Yes. And my friend should be coming with that at any time. It's in my backpack. All of the studies, please, that I've clearly labeled. And they called me and I didn't get them because I was running in here too fast. So yes, I will bring those out. So we have clear data. I think the other part of the puzzle is I never had suicidal ideation myself. And so I was like, well, I didn't. Why am I different? And I'll tell you why. Thank you, Mom. I had the support of my mother, the support of my father, the support of my church, the support of my school, the support of my friends, the support of people I dated. I had all support. I wanted to stay alive and stay here. But that is not the truth for the overwhelming majority of my patients. And when we lose those supports, one after the other, after the other, after the other, that's when we're at risk for mental health issues. And we can turn to things like alcohol and wishing we weren't here. And suicide is a part of that. So I can bring them out. I've annotated them for you as well. We have some with control groups if you're excited about those. Pubertal suppression control groups. These are all mostly from the last 3 years. So after this 2018 data that y'all keep talking about, we got more and new stuff that I want to make sure is informing y'all's practice. We even have control groups with transgender people, youth on testosterone versus those who are not on testosterone. So the control group of actual transgender people, psychoneuroendocrinology as the chapter. I will note that the person, Sapiro or Jesse, before he said he published, he's not in any peer-reviewed journals. I just wanted to make that clear. He's on Psychology Today. He's not in any published peer-reviewed journals. I'm in dozens. So I want to make sure that we're clear with our expert witnesses. Dr. Cooper, who's going to present later, they have a paper on hormone therapy and decreasing depression symptoms, anxiety symptoms as well. And I want to talk about, we talked a lot about it reduces suicidality, it reduces depression, but there's good things too that come with the treatment. There's like good positive, not just getting rid of the negative, but also positive body image, self-esteem, participating in school, getting better at academics, participating in different groups, joining society, coming back to life. These kids wake up and come back to life. And so we got all of these longitudinal hormones.
I'll tell you what.
What you need.
I surely appreciate it.
Yeah.
Why don't you go ahead and leave those with Dr. Oliverson?
Please, and I would love to personally review any of these with you.
Yeah. And then I don't have any more questions for you, but I really appreciate you coming, providing us with that. And thank you for your time.
Thank you so much.
You bet.
Thank you, Madam Chair. Doctor, thank you for being here today. You said something earlier that troubled me, and that was when you were talking about observational studies.
Sure.
You said that the basis for our understanding of how statins work is through observational studies.
Through
but that's
low-quality
in fact not true.
Low-quality evidence.
Multiple randomized controlled trials and meta-analysis on top of that, systematic reviews that document the effectiveness of statins in terms of lowering cholesterol as well as preventing the recurrence of heart attack. I think what you're talking about when we talk about observational studies is more along the lines of, does coffee lower the risk of cancer? Does chocolate help improve mental function? These are observational studies where they look at a large population subsection. They do their best as they can to try to eliminate all the confounding variables. But at the end of the day, it's neither prospective nor is it randomized.
Right. And the randomization of, if we talk about why don't we have RCTs in this particular population?
Yeah, because I think that's a true limitation of pretty much everything you're talking about.
It totally is. And I get why people are doubting our science. I totally get it. I went to medical school. I got my PhD. I do research.
Good.
The issue is when we know a treatment is successful,
but
if
do you
we
know?
Put them absolutely without a shadow of a doubt.
There are randomized controlled trials that say so. So you don't really know. It's observational.
No. And we make plenty of medical decisions based on observational data. And I absolutely know from my own clinical experience, from participating in international conferences, learning, being educated, meeting hundreds of patients.
International conferences. Let's talk about that. There have been 4 systematic reviews looking at this issue abroad.
Which issue?
And none of them looking at the issue of whether these medications are helpful in treating gender dysphoria and or lower the risk of suicide.
Have any of those been published in peer-reviewed journals?
Well,
the answer is no.
I think the answer is they have been.
They have not.
Have any systematic reviews that support your position that these are helpful?
We do, and one is in there. It shows less than 1% regret. It's a meta-analysis and systematic review as well. It's in there.
Oh, okay, great. I'm going to look for that. You wouldn't happen to know the author's name by chance, would you?
I could find it real quick if you'd like me to.
Sure, that'd be great. This might take me a little while to read this here, but...
No worries. So that particular article is specifically on surgery and outcomes in surgery and regret in surgery. And I want to take a moment to talk about regret. I think this is really important because whenever I was going through the Rosenberg Clinic in Galveston, they don't have it anymore. The providers, they've passed away. It's been so long. And they were very worried that we would regret treatment, regardless of what age that we were starting. So I started testosterone at age 24. I'm 39, going to be 40 this year. Woo, I'm still in school. And so they were very worried about regret. And they were very much like, anytime you want to stop treatment, we can stop treatment. No problem. It's not a problem. We'll still take care of you, which is what I tell my patients to this day, because that was important for me. And so in my own practice in psychology, what I'll do is my initial questionnaires for my patients is I say, do you have any regrets related to your transition so far? If so, what are they? Because I'm worried about this too. The overwhelming majority of my patients say, nope, I have absolutely no regrets. Of the patients, probably about 1 in 10 who say they have regrets, 99% of them say, I wish I would have started this sooner. That is my regret. The one person who said they have regrets and it wasn't about starting it sooner said, I wish my mom would still accept me.
Okay, I'm still looking over this. I'm probably not going to be able to get back to you right now, but we'll have a conversation about this later.
I would love to.
I would like to know, though, by the way, that so meta-analysis here, looking at this, were these surgeries all performed on children?
No, we don't perform surgeries on children. You know that.
Well, actually, I know that we don't perform some surgeries on children, but I think we've heard testimony that you do mastectomies on girls
I'm not
under
a surgeon.
the age of 18.
I don't do surgery.
Well, I understand that. But since you're quibbling with me, I just want to set the record straight on that. That obviously,
I want to be clear.
we know that does happen. At least the top surgery happens.
Right. No genital surgeries. That's correct.
Well, but the top surgery is not reversible either.
That's correct.
Yeah.
Plastic surgeons will tell you, oh, we can put breast back on.
Seen that a lot.
You already know.
Let's talk about WPATH. I want to understand why there's such a disconnect between the European community looking into this and doing at their level best to understand the research and study it. And maybe they even have better funding than we do because they have national health services and we don't. Why do they come to such a dramatically different conclusion with regards to gender affirming care?
What conclusion are you referring to?
So I'm referring to the fact that you have country after country that has rejected the idea of gender affirming care, which WPATH promotes. And they've actually started closing a lot of their child gender clinics in other countries, right?
No, there's
no.
Been one
You're telling
hospital.
Me that Tavistock is still
Please
open.
Allow me to finish, Representative. There's been one hospital in the UK that closed. However, they're not going to stop providing gender affirming care. They're opening it up to regional hospitals. So the idea that they're stopping providing gender affirming care in other countries is false. And I don't appreciate folks continuing that narrative.
Well, that's certainly not what the CAS report said. And they actually shuttered the clinic because they felt like it wasn't evidence-based.
They did
right?
not. No, that wasn't the case. They felt like the evidence was very low quality, as we talked about.
Right.
Which we know,
okay.
And we still have a preponderance of evidence. But they said, you know what? Different countries have said we need to study this more, and they put they're following the same standards of care. So I'm not seeing these huge changes in standards.
Well, they're obviously doing something differently because they're not doing the pediatric gender treatments that they were doing.
Some of them have stopped all surgeries completely, but many
look like they stopped more than just the surgeries. It looks like they've stopped, and then we have other countries as well that have put out the same systematic evidence to reverse some of these things, or at least put the brakes on it. I guess the question I want to, what I want to understand is, again, you're making I think what you're saying is that there's no difference between the Europeans and the Americans. I think the bulk of evidence would suggest that there's a lot of difference.
That's not what I'm saying. Bottom line is I'm here about kids. And Europe has not banned care like this bill would do.
But they have significantly turned the corner on doing what we're currently doing in America. They are not allowing children to essentially make the diagnosis and drive the train as far as self-identification, which is what WPATH recommends. Yes?
That's not true. Children do not make the diagnosis.
Really?
Licensed healthcare providers make diagnoses.
By talking to the children.
Which is the same with depression, anxiety, and other mental health professions.
So the children who are adolescent or pre-adolescent who apparently are going to undergo treatments which are life-altering, you would agree that many of the treatments that these children undergo are not reversible.
Many of them are not reversible. Some are partially reversible and some are reversible.
So there's no going back. I mean, if you make the wrong call as a 12-year-old, I mean, we've just heard testimony from folks that obviously it didn't work out for them like it was promised.
And there are some that it absolutely does work out and they need access to care that this bill would cut off from them.
But how do you self-regulate as a profession when you have a treatment failure rate that seems to be growing at an alarming pace?
I have 3 studies that are more recent that show only 2%. So I'm not sure what research that y'all are looking at, but I can give these to you. And they're international as well. there's two of the three here.
The other question I want to ask you is, are you familiar with WPATH 8's decision to remove recommendations regarding a minimum age limit on gender-conforming surgeries?
Yes.
Why did they do that?
That was a big argument that was going to happen up until the day of putting it out there. We're all clear as a field that this is a highly individualized care. There's not the same two people that come in and I say, okay, you're going to need hormones at this age, you're going to need surgery at this age. That's just not how it works. It's very individualized. And so if we put age limits, we would not allow for the individualization of care. And also, as puberty keeps starting earlier and earlier these days, if I got a kid that's starting puberty and is in precocious puberty, I need to be able to take care of them. But if I have a guideline that says you can't do anything till 12, this
Why
person
12?
is stuck.
I mean, you were just saying a second ago, we don't do surgery on
I'm not talking
adolescents.
about surgery. I'm talking about pubertal suppression.
I'm talking about surgery.
Therapy.
I'm talking about them removing there was, if I remember correctly, if I read correctly, in the earlier versions of the WPATH guidelines, there were recommendations on a minimum age limit for surgical, gender conforming surgery. My understanding is that's been removed in WPATH 8. And my question is why? Especially if we're arguing that these things never happen on adolescents, why would the leading organization promulgating so-called standards of care in America basically remove any guidance as far as minimum ages for surgery?
Because they wanted to put that into parents' right to protect their children and physicians' right to work together, collaborating with families to figure out what the best care plan that with that patient would possibly be.
So what you're saying is left to the providers to essentially, do what they think is best in consultation with patients and family members. We very well could see surgeries on children under the age of 18. According to WPATH. And that may be perfectly normal, okay, super good stuff.
This is adolescents that we're talking about.
I'm talking about people under the age of 18.
Very rare cases, incredibly rare cases.
So it does happen.
Incredibly rare cases.
But it does happen.
Of course. Very
You just
rare
told us that it doesn't happen.
I said genital surgery. Let's get really clear, because I think you and me really are on the same page.
I'm not sure we are.
I think that you and I both want to take care of the adolescents in this state of Texas. I think you and I both have an investment in their health care and keeping them alive. Is that true?
I think that you believe that what you're doing is evidence-based and supported by multiple independently confirmed trials. And
Which I have brought.
strongly disagree with you. I think you are operating in essentially a scientific no man's land where you are, as by your own admission, using extremely small sample sizes that don't lend themselves very well to research or control groups or randomized controlled trials. And you are just sort of figuring it out as you go along.
I showed you a trial of 20,000 people. I'm not sure
and how much of that was survey?
What else do you want?
I want actual prospective trials.
Where are you?
That is where medicine finds its strengths.
Have you been funding those? No. What I really need this committee to know is that there are adolescents who absolutely, it is medically necessary that they receive this treatment, period. And this bill would completely ban their access to life-saving treatment. So if we want to get and work together, which I hope we do, then we need to work on the regulations so that the right patients get access to this treatment.
Okay, last question for you. And I don't mean to be crass, but I'm just trying to understand. So WPATH 8 also put out something that I, quite frankly, have never heard of. But since you know a lot more about this than I do, can you explain what is a eunuch gender?
Sure, it's actually in the Bible. I don't know how many folks are familiar with the Bible, and they talk about eunuchs, and Jesus says some eunuchs come into being eunuchs by themselves.
Is that a psychological condition that somebody expresses a gender identity that they want to be a eunuch?
I don't have experience working with eunuchs, but I do know that the idea of eunuch has been around for thousands of years, and there are folks who come to treatment. They haven't come to my office yet that still need supportive care and standards of care on how to work with them. And we finally now have some standards of care set for this population.
Interesting. Okay. I mean, you learn something every day. I appreciate you being here, Doctor.
Representative Tinderholt.
Thank you, Madam Chair. Thank you for being here today. And I have to tell you that I think your resume is pretty impressive. Mayo Clinic is pretty impressive. Rice University. I don't have the wherewithal to do the amount of school you've done. It's a lot. And
I'm tired.
I bet. I have to ask about the button because I've been looking at this button on your jacket, and I'm just out of curiosity. Can you tell me about the button? Because it must mean something.
Absolutely. So I have to cover up,
Sure.
the institution. This is actually my mom's button. It's Mother Mary and Jesus. And so Catholicism is an important part of my identity. And I truly believe that Mary is someone who speaks for the voiceless and who is right there with folks who usually get made fun of or not taken seriously by the governments and people in power.
I will tell you that because of that button, I'll tell you that I think that the heaven above makes children in his image, and he makes them perfect when they come out of the womb. And so I would disagree, but so you're a psychologist in 27 states and a doctor in 2, and you're going through your residency.
I'm a psychologist and a physician, and I'm licensed to practice in the states that we had already discussed. Yes.
So how, because I don't know, how would it work if you're practicing both? Will it be legal for you to refer patients to yourself? Because I don't know.
I won't be doing that. I'll be practicing
But can you?
separate.
Could you?
It's a legal question. There's no precedent for that.
Okay.
And I'm not about to test it.
So I'm a little concerned.
No thanks.
I'm a little concerned when you say you use the terms medically necessary and life-saving treatment.
Absolutely.
We've talked to some detransitioners, both earlier today I have, and we'll probably hear from them later. But we've heard today how that exact terminology is used. This is life-saving. This is medically necessary. Would you like your child to commit suicide or have these services? That's concerning to me because I disagree with you. You are very educated, but I disagree with you. I think when people think that there's something else, and look, I don't disagree that they feel that way, but we normally get them medical attention in regards to mental health. We don't transition, we don't do things to their body. And so I have serious concerns over it. I'm going to ask you a series of questions, and I'm hoping that you'll answer these for me because you are a medical professional. Same question. What's a woman?
Absolutely.
What is a woman?
What is a woman? So in general, most women have XX chromosomes. They get a bunch of estrogen at puberty. They have ovaries, they have a uterus and a vulva and a vagina.
Can any man have a baby?
Any man who has XY chromosomes, testes, and does not have a uterus cannot have a baby.
Okay. So if this bill passes, will you use any loopholes to ship medication to Texas or to bring people to you in Minnesota to do the things that you do with puberty blockers or with hormones? Will you do that?
Well, that's a great question. All I know is that people deserve access to care. And if this state decides that transgender adolescents cannot have access to care, then I'm going to work with legal teams to work to change that. If the bill says that I'm not allowed to help folks cross state lines or access that, then I'm going to follow the letter of the law.
So if you're doing them in Minnesota, but you have your license tied to Texas, I would think that it would. I'm certainly going to ask the author and some legal folks.
If the patient's in Texas, that's where that counts. But
So
if my patients are not in the state of Texas,
So would you do that? Would you bring them to Minnesota to do whatever it is, surgery or transition or medication?
I wish I had enough money to be able to help people access care.
The question is, would you bring people to Minnesota to do it?
Personally, no.
Well,
But I would be in support of folks who are trying to help others access health care. Absolutely.
now I'm going to challenge you on the fact that no surgeries happen.
That's not a fact.
Well, a moment ago, you said these surgeries don't happen. And I'll tell you, I'm not going to give you the clinic. If you want to know, I'm not going to say it here. I'll let you come up and look at this. But there was a doctor in Austin that at the bottom said top surgery in patients under 18 requiring 2 surgery referral letters from mental health care professionals to conduct surgery. It happens. And this individual, now, if you go to their website, has removed that, ironically. I disagree. You say that surgeries don't happen to the children. I'm looking at the website that was pulled up.
That was mastectomy, which is considered top surgery. I was referring to genital surgery.
So
Which
you
does
know,
not happen.
so are you saying that you know what types of surgeries this doctor was doing?
I'm not sure which doctor you're talking about, so it's
you
sort of
can't
hard to
say,
answer.
that's my point. So you can't say that it's mastectomy, right?
I mean, that's what you said. So
No. I said that surgeries for patients under 18 require 2 letters. I didn't tell you what types of surgery. I haven't read the whole thing.
Sure.
I'm just telling you that I believe that what you said is not accurate. It's just not. The surgeries are happening to children in the state of Texas.
Not genital surgeries that I am aware of.
Okay,
or have
see,
been
but that's a
involved.
different answer that I'm not aware of. To state something as fact is not fair when it's your opinion or your knowledge. I think that's disingenuous, and I'm concerned. I'm concerned that you might carry 2 licenses and bring people to Minnesota as well to conduct these. I look at these differently than you.
I'm okay with us having different ways of
I agree.
thinking, but I'm not okay with limiting access to healthcare for a population of people.
But when you're talking today, you're using the exact same terminology that other people tell us is used, that it's life-saving and medically necessary.
Absolutely, which is agreed upon by multiple professional associations, AMA, APA, Pediatric Endocrinology Society, Endocrine Society.
So they say that this is medically necessary and it's life-saving to transition or use medication and hormones.
In certain cases, yes.
For children that are 12, 11, 9.
In certain cases, yes. I said, with any medication, it's a trial. Start someone on puberty blockers, and if that medication is not working for them and it doesn't work, it doesn't work.
I respect all the work you've done, but I have serious concerns, like the author of the bill does, about the data that's being used and the research that's been done, the lack of it. And so I can't support it. I can't trust the data that I hear.
And I need to know what your commitment is to helping kids who actually do need care to obtain it.
My commitment is to stop allowing the mutilation and gender modification of children in the state of Texas.
I don't want any mutilation to happen to you.
I'm just telling you, you asked me, that's my commitment to you.
So it sounds like the youth who do need the care, you are okay with them not being able to access it in our state.
I think that they need mental health assistance. You asked what my commitment is, and that's what my commitment is to stop children in the state of Texas from being taken advantage of.
Can we really get some funding for these youth for this mental health treatment?
And you keep interrupting me. That is my answer.
I would love the funding for that mental health that you suggest, sir.
Thank you.
Representative Smith.
Just trying to get down to some details. Have you had a chance to look at the bill by chance?
Yes, in the latest edition that I found, yes.
All right. Under one section of it, it lists out a number of procedures, and I just want to make sure I understand your opinion on this. It lists out a number of prohibited procedures that it would make them illegal for the purpose of transitioning a child's biological sex to perform a surgery that sterilizes the child. Would you think that a surgery for the purpose of transitioning a child's biological sex, which sterilizes the child, falls below the standard of care?
In terms of genital surgeries that sterilize a person, those need to be done 18 years of age or older.
Okay,
so I'm fine with that.
So that's a yes? Yeah, in other words.
However, you do list many procedures that do not sterilize, and I'm not in agreement with that.
Okay, so let's just go down to this list. Castration. You would agree that to perform castration for the purpose of transitioning a child falls below the standard of care?
They need to be 18 or older.
Same with the vasectomy?
A vasectomy, I don't have any patients wanting a vasectomy at this age, so I wouldn't refer for that. I don't even know why that needs to be on the bill. That doesn't make a lot of sense.
I'm sorry, but did you say mastectomy?
Vasectomy with a V.
Yeah.
You're right. That's very close.
I'm
One letter
going
off.
down to the
Very
list.
different surgeries.
It's on there.
Yeah, and that's not it. Vasectomy is actually not a gender affirming surgery, so I'm not quite sure why it's on there.
Okay, so
no, we agree.
Okay,
No.
we agree on that.
Move along.
Hysterectomy.
Hysterectomy is sterilization. And so I think the issue is if they have an actual medical condition where they need the removal of the uterus, we have to have a clause for that because that does occur in some cases. But if they don't have a different medical condition, then 18 would be appropriate.
And I think that's covered because it's for the purpose of transitioning a child.
Okay, same page.
Is
Yep.
qualifying.
Okay.
Okay. Oophorectomy, I don't know if I'm pronouncing that right.
That removes the ovaries and sterilizes, so I agree.
Metoidoplasty.
That does not necessarily, doesn't take out any reproductive organs.
What is that?
So metoidoplasty is a surgical procedure to, if somebody's already had testosterone, it takes the clitoris and it makes it more prominent, so it looks more like a penis. I don't have anybody under the age of 18 having metoidoplasty, so I think it's fine to make that 18 and older.
Excellent. All right. Orchiectomy.
Orchiectomy removes testes. That's sterilizing, so I agree, 18 and up.
Penectomy.
Penectomy, we really don't have penectomies. That's not how genital surgery works. We don't cut off the penis. Like, people are very misinformed about that. That could lead to sterilization. So 18 years old would be good.
Phalloplasty.
So phalloplasty, the creation of a penis. If they keep their uterus and ovaries, they're still fertile, but I have no patients, and I've heard of no patients on record that have had this below age 18. So 18 is fine for phalloplasty.
And vaginoplasty.
Vaginoplasty or vulvovaginoplasty. In most cases, this is going to be sterilizing. So in Texas, we could do 18.
And now let's talk about mastectomy.
Sure.
would it fall below the standard of care for the purpose of transitioning to take a child through a mastectomy?
These are very rare cases, and in some cases it would be standard of care. I think the other thing you have to think about is there are plenty of Texans who are 16 and have had a breast augmentation, and there's no issue with access to that. And so if we're going to keep allowing that in non-transgender patients, then we shouldn't have a different standard for transgender patients. And what we always see is when we're trying to make standards is folks trying to remove things from trans people. That's like always the case. So I want to notice that we're doing that again.
Is it, doctor, do you know if it's true that once a child on...
Would you mind speaking into the microphone?
Yeah, sorry. Is it true that once a child on Lupron, and then testosterone for a period of a few months, if they are, that is irreversibly sterilizes the child?
It depends on which Tanner stage they start the Lupron at. And so if they start the Lupron when they've already had a menstrual cycle, then yes, they will be able to be fertile again in most cases. But we didn't test their fertility before we started, and we're very clear with that with patients. However, if they start at Tanner stage 2 with Lupron, a pubertal suppressant, and then if the family makes the decision to go on testosterone, one of the very clear risk and benefits that we discuss with parents is that we do not believe that they will be able to be fertile in the future if this is the decision that they make.
And that difference between Tanner 1 and Tanner 2 is really based on the health.
Hair, it's a physical exam that a medical provider has to do to make that determination. That's always done before we start pubertal suppression, always.
Okay, so would you mind that particular situation falling below the standard of care for a child, for the purpose of transitioning a child?
No, the parents deserve the right to decide with the physician if that's an appropriate course of action, as long as they go over the risk and benefits.
Thank you, doctor.
Representative Jones.
Pardon me for my ignorance, but I would really love to know, why is there such an overemphasis on the removal of breasts if we're having a conversation about sterilization?
I'm not leading the conversation, so I'm not sure why they're asking these questions in the way that they are.
Thank you very much. And so the next question is, there seems to be some situations where it is appropriate for mastectomies under the age of 18. Could
Absolutely.
you speak a little bit about that? Because it seems like there was, I think for me, and I'll just speak to my own ignorance, there seemed to be a confusion around sterilization and mastectomies because we keep on talking about them.
So mastectomy is removal of breast tissue. That if I had a mastectomy, I will be open about that. But that didn't make me infertile or sterilize me in any way. It made me be able to confidently walk outside my house in Houston, Texas, in the middle of the heat and bring out the trash without a shirt on. It made me comfortable to open the door to the pizza person without a shirt on. It made me comfortable to walk down Galveston on the seawall and to be very proud of myself. It changed me in a way that I don't even remember what it was like before I had a mastectomy. It was such a positive experience. And in terms of, younger and younger people, when you have these young folks who have double D breasts, and our medical advice to them is to try to live in the social role of male, if you have double D breasts, that's almost impossible. So many of them will wear binders and they'll get rashes under here and get acne and all sorts of issues. And so in very rare cases, I want to be very clear, most people have mastectomy after age 18. Let's be really clear. These are rare cases, but they do exist with proper psychological assessment and family preparations where it is medically necessary before 18 to have a mastectomy, which does not sterilize the patient.
Thank you. I appreciate that.
Yeah, absolutely.
Representative Jaton.
Yeah, thank you, Chair. I was just looking at the study you gave on the regret after gender-affirming surgery. And it looks like the median age is 30 and 40s.
Yeah, because most people have surgery not even in this area we're talking about, age.
Okay. So the study, I guess the question goes back to, among those that are if the brain fully develops at 25, I mean, just looking at 18 and younger, do you know of any studies that shows the regret factors among those children that end up making lifelong decisions?
So I'm really glad that you brought up the whole brain develops at 25. So I'm a child family psychologist and an expert in development. And what we know is that gender identity develops between age 18 months and 5 years of age, not 25. So I think it's really clear that we need to get on the same page in terms of when does the brain develop, in terms of knowing what gender you are, what genders other people are. Between 18 months and 5 years of age is when that development is typically supposed to happen. But for me, since mine was not a girl and everybody said it was a girl, it was delayed until later. And so I think it's important to make sure that we're clear that we're treating folks based on something that's supposed to develop in early childhood, not things that are supposed to develop like, who do I vote for and how do I become a real adult? Those sorts of questions that develop later.
So society delayed the development, your development in knowing what sex you were until after 5.
And they didn't mean to do it on purpose.
Okay. So it doesn't change. So the question remains of those. So if they're 15, 16, let's say they're 5 years old and they're still trying to figure this stuff out.
Sure.
Do we have any studies or anything to support the idea that at that age, they're able to make decisions that will impact the rest of their lives?
The parents are in charge. And so the parents are the ones that are charged with these decisions. The children and adolescents are sent to treatment.
How do they know what that development factor is in their child's brain?
Sure. So we're not even talking about any of these treatments with children. They have to at least start at puberty. So we're not talking about 5, 6 years old, anything like that. We're talking about folks who have already gone through a gender identity development. Early childhood is done. So these are older folks, right? So they are able to give assent. And also part of the really important assessment process that we keep talking about is making sure that the young person has emotional and cognitive maturity to make this decision. So I'm on the same page that we need to be making sure we're doing that. And that is already part of the standard of care.
Well, I think that's part of the debate that we're having, right? Is that, so and you even mentioned the society impacts whether or not, it has an impact on whether or not you fully understand what you are. And that, when you're going through your adolescent years, especially, people convince you of a lot of different things. The concern that we have is that ends up happening at an age when they don't know the repercussions that are going to be for the rest of their lives. And we are talking about them seeing a psychiatrist and answering questions in that, that mental health professional making that decision based on what they're told only, because there's no way to point to anything in the brain that says, all right, this confirms this is accurate. And they're being referred to a doctor who is making decisions that, while confirmed by a mental health professional, is still based on a child's assessment, their own assessment. And so this is what we're worried about. And this is what we're trying to understand. And when we look at whether or not there's regret, that's the study that we need to see. And I will add to this that the state of Texas invests heavily in mental health and is substantially increasing that in this session because we do recognize that as an issue. But part of that mental health services is going to be helping people where they're at, especially when they're children, because there are a lot of decisions that they're just not have the capacity to make at that age.
And that's why the parents' rights are so important to protect their children. Then they need to be able to access healthcare and experts in order to make the best decision for their family.
To the extent that it doesn't have lifelong impacts. A lot of the stuff that we talk about within mental health, when we talk about providing assistance, they usually don't have lifelong repercussions. When we talk about depression, when we talk about a lot of different things, you're talking about putting them on medications that help stabilize and helps them to process and understand where they're at. Usually they don't have lifelong impacts.
Lack of access to them absolutely does, including increased risk of death, which is also what we're trying to talk about as well.
Repeat that last line again.
Lack of access to depression medications does have lifelong effects on people. Same with lack of access to care for those who need it in my community.
The difference being that when you get on depression medication, it has an impact at that moment and doesn't potentially have lifelong.
So it typically takes at least 4 to 8 weeks, doesn't have an impact at that moment. And similarly, with pubertal suppression, with hormone therapy, we don't just start them on treatment and say, see you later. We have very close follow-up, at least monthly to every 3 months, to make sure that intervention is correct for that person. And so that's why it's important to see folks who know what they're doing in this area.
How do you determine if it's right for that person?
It's everything is a trial. So my parents asked that exact same question to Dr. Walter Meyer.
Is it affirmed by the individual?
Can I please answer your question, sir? Thank you. My questions, and I think that's a very important question, is how will we know if this is right for the child? That is the crux of the matter. And so I want to make sure that everyone hears this question is so important. My own parents, I'm an only child, and they're both doctors, and they're trying to figure out, they've never heard of this. They don't really know what they're doing. So they talked to Dr. Walter Meyer, who's one of the leading experts who started pubertal suppression in the state, actually, and is widely regarded, internationally known. And he said, you know what? We can't know. Every medication is a trial. And so that's why we start with the fully reversible medications, and we follow up closely with them. And then we see what their response is to that intervention. And if this child comes alive, if this child is no longer thinking about death, if this child is interacting with their family, we have to look at that response to intervention. We can't deny that.
So to confirm, you are saying that the affirmation is their emotional state that changes.
The response to intervention is how the young person responds to intervention.
If they come alive.
That's one of them, yes, that I hear all the time from families.
How long does coming alive usually last?
It depends. Does their church want them to come anymore? Do they still have friends? Did the person they were dating break up with them because they're trans? Do you see all of these outside supports are so important?
So again, I think we're getting back to the impact society can have on whether or not an individual, an adolescent, is getting the care that they need. And we should be able to, I think there is enough evidence that teenagers are usually spending most of their teenage years trying to figure themselves out. And for them to spend that time making decisions that will have lifelong impacts is a dangerous, it's a dangerous thing. And I think it is, I think that's inaccurate. I will have to disagree with you on that.
We require parental consent for anyone who's under the age of 18.
I have no doubt you require parental
consent.
So, all right, I will leave it at that. Thank you.
Thank you so much for the conversation.
Other questions, members? Representative Jones.
Earlier in your time here, you were talking about the importance of peer review journals. Why is that important?
Because anybody can publish things online and say they're published, but we have to hold our colleagues who say they're published to a standard, a professional standard. And so when you were asking that gentleman, do you conduct research? And he said, define research. That's a big red flag for me. You know, if you do research, you went through the IRB committee, all of those things. He has not done that. He has not published in any peer-reviewed journals. So it's important if somebody purports themselves to be an expert to be able to clearly answer yes or no if they've done research, and also if the publications that they have made have actually gone through a peer review by a jury of their peers or colleagues who are experts in that same area. And that gentleman failed to meet that criteria.
You said you're a PhD in what?
Clinical psychology, child and family, University of Houston, go Cougs. I knew it.
You said you're an MD and you specialize in what? Or you're trying?
Family medicine. I take my boards in less than a month. Say a prayer.
I've heard a lot of testimony about you give surgeries, I guess genital surgeries to children. Let me finish.
Oh, yes, ma'am.
You've heard a lot of testimony about genital surgeries being performed on children.
Mm-hmm.
and then they get older and they have regret or you can't go back.
Mm-hmm.
Right. So I'm just curious. You've been here all day today.
Oh, yes.
Have you been here all day today?
Yes, ma'am.
Did you hear anyone who testified there was actually a kid that made this decision that got surgery and then regretted, or did you hear like I heard, like everybody was an adult and made the decision? Okay.
Correct.
Then also you've heard testimony today where they talked about it's irreversible. I want to sort of reverse the analogy. So you're a kid, like my client who was getting in the girl line when she was in pre-K.
Mm-hmm.
And didn't learn about it on the internet. They have no peer pressure or none of those things on the internet where they say you can go there and be made crazy and brainwashed. None of that existed. You know that you are trans. Well, you don't know it's trans, but you think you're a girl.
Know
but
what you like.
You got, right. So then they don't let you get surgery and you have to wait until you're 18 before you're allowed to have surgery.
Genital surgery, yes, ma'am.
Yeah, genital surgery.
Yes, ma'am.
So this is what I'm thinking. Tell me if I'm right. If I know I'm a girl, I was born in a boy body, and I don't want to get buff. I don't want to have broad shoulders. I don't want my Adam's apple to come in. I don't want my bones to be whatever, because I know the difference in my son when he went to college and when he came back, he was a boy when he went. When he came back, he was a man, right?
That part.
He gained 50 pounds from the time I dropped him off in August of 2010 when I picked him up after his freshman year. In May of 2011, he gained 50 pounds and grew 4 inches. Wow. Right? If I know I'm a girl, even though I'm born in a boy body, if I start taking whatever that healthcare stuff is, right? I'm not about to
medical treatment.
Yeah, that part. If now at 18 I'm 6'5", got a deep voice like this, can I go back? Can I go back and be feminine with at 18? You give me hormones.
It is much, much harder. So just like we talk about, some of the hormone treatments are irreversible, partially. Same with your own puberty. So if you already have a deep voice, I can't change that. We have some surgeries, they're not great. If you already have a beard, maybe we can pluck that, but it's still there. It's still going to grow. So it is much easier, and the treatment works much better with early intervention in the appropriate cases.
So if I'm forced to wait until I'm 18, then I will not be the woman that I was born to be. And I don't even know how to explain it. I can't go back and be, 5'6", and petite.
Yeah.
And with feminine features.
That's so true for so many of my patients.
Because I remember when I was little, in elementary, me and the boys would go head to head, I would whoop them, right?
That's right.
And then I remember most in middle school, kickball, dodgeball, and all that stuff. That's when the boys started being bigger, stronger, faster than the girls, right? But are you suggesting that the science shows that if we're able to stop it when kids know who they are, that they're more likely as adults to be who they are?
Absolutely. We have plenty of research showing that. And folks that, when I talked about the regrets, they say, I wish I would have started sooner. That's exactly what we're talking about. And only going through one puberty sounds great.
You know what's really interesting to me?
Tell me.
Is anybody else came up here, Mayo Clinic, Rice, Go Cougs, specialty in this very area, I mean, correct me if I'm wrong, you're studying like in this very area about what this bill purports to regulate,
internationally
correct?
recognized expert.
I'm just surprised that, I'm just surprised that you actually have like actual education in what we're talking about, and people are trying to dismiss that. And
the people that generally have the strongest negative opinions typically know the least, and unfortunately, some are willfully ignorant.
And I'll say this: I mean, some people believe from the depths of their soul they're right, right?
Sure.
Even though
We
they're
all
wrong. But I guess my question is, there were a number of times where you were trying to talk, where you asked a question and you started answering, and then you got cut off. So then I guess my question is there anything that you wanted to say that you weren't allowed to say to help us understand why listening to kids and their parents and their healthcare providers to make the best decision for that child is important and is based in science? Can you just share that? Because you did get cut off a lot.
Thank you, Ms. Jones. So, bottom line is everyone deserves access to healthcare, period. And for transgender youth, there are clear standards of care that keep getting updated with newer and newer research, just like any other area of healthcare. And the idea that because we have low quality evidence, which is the same standard that many other healthcare prescriptions meet, but we're not trying to ban those, is a direct affront to my community. And it's very much targeting us. We are supposed to be held to a higher or different standard than general medical guidelines. And that's inappropriate and fueled by bias, is my clear perspective that I've seen for many years. I also want to be very clear, because we keep talking about genital mutilation and surgeries on children. And so I want to really get clear with the record here. I think it would be important, if you're going to pass anything, to have exceptions for the young folks that really need the care. I am fine to sign on with no sterilization until age 18 or later. I think that's a good compromise that we can work together and make. And different states may do things differently, but I think Texas is Texas, and I think that's a fine concession to make. We do need to know that the genital surgeries that are performed on children are for intersex children. And we've talked a little bit about them before. The one issue I take with testimony previously is they've said only if it's a medically necessary condition. So like, let's say a person's bladder is born on the outside or the urethra doesn't allow them to urinate. Absolutely. However, there are cases of genitalia that doesn't look exactly like a penis and scrotum or a vulva, where there's actually nothing anatomically wrong with the child, that genital surgeries are actually being performed without the consent of this person. That does occur. So I want to make sure that folks do understand there are genital surgeries being done on children without their consent in intersex children, and not always with a medical indication, sometimes with only a cosmetic indication. And you may hear from some of those folks today.
And then I guess my final question is this. So some of us aren't doctors, like me. Well, I'm a doctor of jurisprudence, but
yes,
not related to medicine. Just give us some examples of you're younger than 18 and you need to have surgery. Like, give me some examples of that, please.
Sure. So, goodness gracious. So young folks, probably 16 years old would probably be the median age come in. They've been trying to live as a boy since they were in daycare or 7 years old, for like almost 10 years of their life. The majority of their life, they've been trying to live as a boy. They go to the locker room, they try to change. They're trying to live in the social role of boy, which is what we require before treatment. And they're not able to do it. They'll change in the bathroom, or they just won't even go to sports at all. They many of my patients will wear these huge hoodies when they come into my office, and they'll have their back sort of like this in order to try to hide the breasts. They'll wear binders and other things that we try to do to help them appear more of a flat chest. Some of them, unfortunately, will do cutting on this area because it's so foreign to them and doesn't make sense. And so in cases like that, where we have that severe dysphoria that for years has persisted, not knock, knock, I'm transgender, can I have surgery, that some people are talking about, that is not standard of care. We've been working with these families, we've been following them, and the person has been very clear. Most cases won't have surgery before 18 because most parents will not get on board. And that's okay because parents have the right to decide about their health care for their child. But those that do, and it is medically indicated, do really well. We do have a study, actually, I didn't bring that one because we weren't talking as much about surgery, but mastectomies. Johanna Olson-Kennedy did show the positive mental health effects of mastectomy in transgender boys. So that has been shown. We do have research on that.
And the last thing, you gave Dr. Oliverson a bunch of, I guess, treatises or
empirical, peer-reviewed.
Yeah, so I'd like that. I mean, you don't have to give it to me now, but can you get it to my office, please?
I'll give it to you right now. I brought this for you.
Is there only one copy, though?
Yes, but I can email everybody.
Okay, so why don't you do that? I want him to have it because he asked for it first.
Okay, we will email all the committee members, all the research studies, including the one on mastectomy that we just discussed.
Okay, thank you.
Yes, ma'am.
Other Representative Jones.
Y'all, I'm sorry, but I'm about to go there. I just have one question. When we talk about, and I've worked in public health, but this is more community health. Wouldn't you consider male circumcision gender mutilization?
Good question. So it is not my area of expertise. I do not perform circumcisions, even though some family doctors do. It's not part of gender affirming care. So it's not related to this bill. Mm-hmm. So it's not in my mind related to anything that we're talking about here.
No, I appreciate it.
So
I just asked that question because we that word has come up all day long.
Yeah.
And so when we talk about, there's a lot of things that have come up that's not germane to this bill or conversation. Mm-hmm. And so the definitions, maybe it's just getting lost upon me, but I'm just really wanting to really find a focus back to what we're really trying to talk about. And that's, equitable healthcare, for young people, particularly those, trans experience. And so, thank you for your answer. I really appreciate it.
Sorry, misclick.
Representative Jones.
I have one question. Is circumcision of the penis medically necessary?
No professional associations say that circumcision is medically necessary. However, they offer it because in rare cases it can lower some rare risks, such as urinary tract infection. But there is no medical society that currently says that it's recommended treatment. And I'm a family doc, so I work with babies and we go over the consent form at Mayo Clinic all the time. But the parents have the right to decide
whether to circumcise their child's penis.
Yes, ma'am.
Thank you.
Other questions, members?
I'm sorry, Madam Chair. So we just had to bring this conversation up. So is that also a religious practice for some people?
I really think we should stop talking about circumcision. It's not on the bill. It's not related to trans health.
I kind of agree. I came back in here. I'm not really sure how we got on this conversation.
So I'm going to avoid the question, just to be honest, because I don't think it's relevant to our shared goal of taking good care of Texans.
Great. I agree. It's a bad example. Thank you.
Other questions, members? Thank you.
Thank you all so much.